This is Chapter 11, Disproportionate Fetal Growth. Disproportionate means that it is either less than expected or more than expected. Proportionate fetal growth would be what it should be. We'll start out looking at less than expected, and the term that we use for that is intrauterine growth restriction, IUGR. This used to be in the past called intrauterine growth retardation. It was true that growth was retarded, but the word retarded communicated a wrong message to the parents. These babies are not retarded. So a more politically correct term is restriction, intrauterine growth restriction. Now this is a very difficult definition. It is not a precise term. Estimated fetal weight based on obstetrical ultrasound, we would say less than 5 to 10 percentile. If we say less than 10 percentile, we are making arbitrarily all babies that are below the 10th percentile abnormal. And that is not true for most of those. Perhaps a more accurate definition would be less than 5 percentile. We also use actual birth weight, and at term we think of less than 2,500 grams, which is 5.5 pounds. Now, are all babies that are less than 2,500 grams at term abnormal? And the answer is no. 70% of these fetuses are what we could call constitutionally small. In other words, that's what they should be. The size is appropriate for their genetic potential. Consider, for instance, the average weight of a baby born in Manila in the Philippines and in Samoa. In the Philippines, they're going to be much smaller babies normally. Small mama, small papa, small baby, of course. And yet ultrasound is not easy to identify which are which. And the reason is because we do not have ethnic specific fetal growth tables. Ideally, we would have a separate growth table which we would compare to for babies of Filipino origin, from Samoan origin, and whatever else. But we use the same one. So there's a lot of false abnormals. If you look at the measurements of these babies, these fetuses, the biparietal diameter, the abdominal circumference, the head circumference, they are all symmetric. In other words, everything is small, which it normally would if that's what it should be. So that's the concern with IUGR. Of course, placental insufficiency could cause babies to be small, and particularly symmetrical IUGR if there is some intrinsic problem with the fetus, such as aneuploidy, infection, or anomalies. When we make an assessment of IUGR, it is essential that we have good dating. In other words, we have a good basis of comparison of what the baby should be, because if there's a dating error, we can have a false abnormal. So early pregnancy dating is really important. A first trimester crown rump length is going to be plus or minus 5 days, which is really accurate. If you know when the date of conception was, if it's in vitro fertilization, if it is embryo transfer, if it is artificial insemination, that would be even better, because based upon the early assessment, we can then assess, is a baby appropriate or too small for what it should be? An important maxim is do not change the gestational age based upon a late sonogram. An early sonogram is going to be your best indicator of gestational age and due date. Don't change it if there's another ultrasound which is off, because what that would tell you is going to tell you whether the growth is appropriate or inappropriate, but the gestational age does not change. Here we have a growth table, and you can see on the x-axis is the gestational age in weeks. On the vertical axis is the birth weight in grams or in pounds and ounces. And you can see the various ranges of weight for each gestational age. And they go from 1 percentile on the bottom to 99 percentile on the top. And you can see it goes 1 percentile, 3 percentile, 5, 10, 25, 50, 75, and so on. The average would be 50 percentile. And so the shaded area, which is around the heavy line, is where most babies would be. By using this, we can see with serial assessments with ultrasound if the fetus is tracking on a persistent low or high profile, or is it on the 50th percentile and then it falls off, because that would be quite a significant difference whether it was following its own growth curve or whether it was following a normal growth curve and then it started falling off. Here we can see a very crude plot of weeks gestation, which is on the x-axis, and weight on the vertical axis. But the value of this is it shows you that there is a range for appropriate growth, which would be 10th percentile to 90th percentile. Below that, we would have the small for gestational age. The above that would be the large for gestational age. Now, some of these, which are in the small for gestational age as well as for the large for gestational age, are really constitutionally incorrect. The babies really should be what they are, but we're just not very good at assessing that. We are looking at small for gestational age, which is below the 10th percentile on this growth chart. All right, what are some causes for intrauterine growth restriction? Well, this slide shows that there are three general causes that we think of. There are fetal causes, there are placental causes, there are maternal causes. The fetal causes are usually symmetric, IUGR. The placental and the maternal are asymmetric. The reason the fetal causes are symmetric is because it is a decrease in the growth potential of these fetuses. It is intrinsic to the fetus. It is because of the cells which are in the body. It's the infections. It is the abnormal chromosomes which may have done it. The symmetrical IUGR is not going to be improved by more nutrition and more oxygenation because it isn't a nutritional problem. It is not an oxygenation problem. There are three areas that I look for if there is symmetric IUGR. One of those is aneuploidy, abnormal chromosomes. And we already looked at previously that babies with trisomy 13, trisomy 18, trisomy 21, will be short stature. Turner syndrome is another one that has short stature. So aneuploidy, this is something which can be screened for with amniocentesis, with chorionic villus sampling. Percutaneous umbilical blood sample would be another way, although not very common. All women who are pregnant are offered the quadruple marker screen, and that would be a screening test for aneuploidy. There is the first trimester nuchal translucency and blood tests also, which can be used. So aneuploidy should be high on our list of differentials. That is going to be symmetric IUGR. Now let's look at the causes of asymmetric IUGR. It could be placental causes because a placenta is not getting enough oxygenation and nutritional substrates, enough carbohydrates, enough lipids, and enough amino acids to the baby. It could be an infarction. It could be an abruption. An old abruption can look like an infarction when you examine the placenta. It could be twin-twin transfusion where you have a donor and a recipient, and the donor twin is going to be IUGR. It could be filamentous cord insertion where the fetal blood vessels from the placenta run over the membranes for some distance before the umbilical cord is developed. See, normally the umbilical cord protects the fetal blood vessels, but if they are not protected by the Wharton's jelly and by the umbilical cord, then there can be decreased perfusion. Even if you have insertion of the umbilical cord on the edge of the placenta, it can give you decreased perfusion. The maternal causes are usually vascular related. It could be hypertension. The mom has chronic hypertension, mild preeclampsia, severe preeclampsia. We would see severe end organ problem with the baby because of the placenta. We could have small vessel disease, such as systemic lupus, such as long-standing type 1 diabetes mellitus. It could be lifestyle, severe malnutrition, tobacco, alcohol, drugs, substance abuse. Any of these could be responsible for asymmetric IUGR. Now, what is it that makes it asymmetric? It means that the head is spared. It is the abdomen which is small. Why is the head spared? The reason is that when it is a substrate problem, when it is a perfusion problem, the fetus recognizes this and will start to shunt blood preferentially from the viscera to the head. And so the blood flow through the middle cerebral artery will increase and blood flow to the abdomen will decrease. The organ that determines the size of the abdomen is the liver. And so you have a small abdomen, but the head may be somewhat smaller, but it is compensatory protected by this preferential shunting. So those are some of the causes of symmetric IUGR and asymmetric IUGR. Here is a table that looks at what I just told you. On the left, we have symmetric IUGR. All the ultrasound parameters are decreased. The biparietal diameter, the head circumference, the abdominal circumference, the femur length, they're all decreased due to decreased growth potential. It could be aneuploidy. It could be infections in utero. It could be gross anomalies that we talked about. We want to do a detailed ultrasound. We want to look for any genetic markers. We will consider doing an amniocentesis for karyotyping and screen for fetal infections. We talked about that previously. What's interesting with the symmetric IUGR is that the growth tends always to be at the low percentile. It's 5 percentile all the way along. It always has been. This is where giving extra oxygen, giving extra nutrition, have the mom at bed rest isn't going to make any difference because it's not a placental problem. There is adequate placental perfusion. And so antenatal, antepartum testing is usually normal. NSTs, AFIs, biophysical profiles, Doppler flow will be normal with symmetric IUGR. But with the asymmetric IUGR, the ultrasound shows head sparing because the brain is not affected to the same degree as is the liver, but the abdomen is small. This is due to decreased placental perfusion, chronic maternal diseases. We talked about hypertension, preeclampsia, diabetes, systemic lupus. The workup in terms of karyotype, infections would be negative. The ultrasound often will show normal growth earlier in the pregnancy and then a falling off of the growth as the vasoconstriction gets worse. This is where the antepartum testing is going to be particularly helpful because we can monitor and follow along to see, is there a decrease in the amniotic fluid index? Will the NST become non-reactive? Will the biophysical profile start to deteriorate? And will we see absent or reverse flow on the umbilical artery Doppler? And we'll be talking about that coming up in the next few chapters. So antepartum testing is usually going to be normal if it is a fetal problem, but it will be possibly abnormal if we have problems with blood flow because of the mother. Here's a pictorial way that I like to look at this. And on the left, you can see normal. In the middle, we have symmetric IUGR. On the right, we have asymmetric IUGR. The normal head, normal abdomen. If you compare the symmetric to the asymmetric IUGR, the symmetric has a small head and a small abdomen because it is intrinsically a fetal problem. With asymmetric IUGR, the abdomen is small, but the head is spared because of differential shunting and perfusion of the brain as opposed to the viscera. So visually, I think this helps to show how these compare and how they look. And remember, with a symmetric IUGR, you would not expect fetal monitoring abnormalities, whereas with the asymmetric IUGR, that's where you might expect to see NSTs, AFIs, biophysical profiles deteriorating. And of course, that would then mean that we need to take a look and determine, do we continue the pregnancy or do we intervene? And you always need to be concerned. Gestational age is going to be probably the main thing which determines whether delivery is appropriate or not. Now we move to large for gestational age macrosomia. This is over 90 percentile of estimated fetal weight or over 4,000 to 4,500 grams at birth. The definition of macrosomia, ultrasound, estimated fetal weight, above 90 to 95 percentile for gestational age. Our ability to predict fetal weight is not very good. Our accuracy is very poor. When we get to the extremes, we may be as much as 400 grams off, which is basically a pound, and that can make a big difference. The abdominal circumference is the primary ultrasound parameter which gives a direction in terms of macrosomia. We would expect to see the head more normal size, but the abdomen tends to be larger. We can also look at macrosomia by actual birth weight, 4,000 to 4,500 grams, between 8 pounds 13 ounces and 9 pounds 15 ounces. Just as many of the babies who are IUGR, SGA are really constitutionally appropriate, that is also true for babies that are large. If we have a big mama, we have a big papa, what would you expect but a big baby? The ideal would be to have ethnic specific fetal growth table. Now we know that there are certain risk factors which would predict macrosomia, and that will be helpful as we look at those. Diabetes, gestational diabetes, and overt diabetes type 1 and 2. Overt diabetes type 1, if there is long-standing diabetes, 10 years or more, small vessel disease, then you might expect an IUGR baby, not a macrosomic baby. One of the concerns about the macrosomic babies of diabetic moms is that the shoulders are disproportionately larger than is the head, and so shoulder dystocia is going to be more of an issue here. Prolonged pregnancy. Obviously, the longer the pregnancy goes, the more the nutritional substrates come across the placenta, the bigger the baby could be. Multiparity. When we look at the weight of subsequent babies, they tend to get bigger as the number of children increases. So a woman who is a grand multipara may have a very big baby. Of course, a lot depends on other things. If she is advanced maternal age, has chronic hypertension, has diabetes, there are lots of factors that can enter in. If we have a 400-pound mom, particularly if she's had high pre-pregnancy weight gain over 35 pounds, that is a risk factor for macrosomia. Gender makes a difference. Male fetuses tend to be larger than female. And if a mom had a previous macrosomic fetus, we might expect that with this pregnancy, she might also have a macrosomic fetus. However, risk factors are not always identifiable and not always as accurate as we would like them to be. Macrosomia. So what's wrong with having a big baby? Well, there are maternal hazards, there are fetal hazards, there are neonatal hazards. Maternal hazards. Bigger the baby, the more likely to have an obstructed labor, a prolonged second stage, can't push the baby out, operative vaginal delivery, vacuum extractor, forceps, perineal lacerations, postpartum hemorrhage from an overdistended uterus, and a uterine atony, emergency cesarean, pelvic floor injury. It's not good for moms to have excessively big babies. There's not a whole lot of good things that happen to the pelvic diaphragm and the pelvic floor. Fetal hazards, shoulder dystocia, and this is particularly so if we have an infant of a diabetic mom. Birth injury, because of having to do manipulations and to get the baby out. If there is problems with oxygenation, asphyxia. Neonatal hazards, admission to NICU is higher with macrosomic babies. Hypoglycemia, we talked about that with glucose intolerance in pregnancy. If there's shoulder dystocia, there could be Erb's palsy. Fortunately, most of those are temporary, but some of them can be permanent. So what do you do? What is the management? Well, if a mom has diabetes, an estimated fetal weight of 4,500 grams or more, it would be reasonable to offer an elective cesarean. If the mom does not have glucose intolerance, and the estimated fetal weight by ultrasound is over 5,000 grams, that would also be appropriate to offer the mom elective cesarean. But as I said before, we are not very accurate in predicting fetal weight. And a lot of these babies that we do cesareans on may not turn out to be as big as we thought. There's also the concern about should you induce labor early? If you have an unfavorable cervix, would that then lead to increased likelihood of failed induction and emergency cesarean? This is a tough subject to deal with. And as we see an epidemic of obesity in the United States and around the world, I suspect that we will see more and more macrosomic babies. Here's an 11-pound baby that was actually delivered vaginally. As I said before, there's no accurate way to predict or prevent macrosomia. Elective cesarean or early induction would be reasonable. Estimated fetal weight over 4,500 grams in a diabetic mom, and estimated fetal weight over 5,000 grams in a non-diabetic mom.